sort of said is, well, maybe it was a negative trial because it wasn't sustained enough. We only went into the operating room twice. And it probably is true that, and I still see it today, if a surgeon is trained in a certain way, when they get back into the operating room and they're in trouble or they're struggling, you always go back to baseline. You always go back to home where it's comfortable, and so you really keep practicing the way you were trained. To actually dramatically change your practice is more challenging. So what we said is, well, maybe we need to do something that's more sustained. As well, the QIRC trial was very top-down. You know, we were the so-called research experts. This is what you have to do. And knowledge translation quality improvement would say that you have to put the frontline person right integrated into the research project. So this is more a surgeon-driven integrated KT project that we call the Quality Initiative in Colorectal Cancer in LIN4. So I said, instead of running around the province, why don't we just focus on our LIN, okay? Our LIN stretches from Niagara Falls to Hamilton, Burlington, Brantford. It's one of the biggest LINs in the province, 1.3 million people, has more people than many provinces in Canada. And there's about 10, 11 hospitals that provide colorectal cancer care, obviously academic, non-academic. So it's a great laboratory to sort of test these new concepts. And we started that in 2006. And I see Sean is here. Thank you very much, Sean. And Sean's been a great supporter. In a nutshell, it's a very simple concept. Surgeons select markers. So this is what I'm interested in pursuing, and surgeons select interventions, okay? And our tagline is supporting surgeons at key points of care. We, of course, care about the patients, but we actually think that if you want to optimize care for the patients, you should be thinking about the surgeons. And likewise, you know, it would be whether it's a nursing issue or a medical oncology issue, et cetera. Now, I will, before we go into some of the interventions, I will say the results are very, very promising over time. But what we don't know is, are these just secular trends? Are improvements happening everywhere across the province because of things like training programs and journal articles, et cetera? So we have an ICHR grant where we're looking at these measures across the province. And we'll be able to tell you in a year or two, are measures in LIN4 relatively superior to measures in other LINs? And then we can potentially extrapolate and say, well, maybe that's due to what we've been doing in the LIN, the group of us. Okay. Sorry, I just wanted to go to the... Okay, so the surgeons sit in the room, and approximately once a year they pick interventions and markers, and here are the interventions, pretty classic: audit and feedback, tailoring interviews, surgical event reporting system. That's kind of like, you know, if your plane crashes. We really haven't, well, that's a good one, taken off on this one, but I think it's very promising. But the one I'm going to really talk about today, I just have about 4 or 5 more slides, is collaborative cancer clinics. Because I finally feel, after about 10, 15 years of research, that we're finally gaining traction on this concept of getting into people's heads and working and creating a more collaborative, supportive environment. And I think the results are very exciting. So Cancer Care Ontario has pushed this idea of multidisciplinary cancer clinics. And again, like so many things Cancer Care Ontario does, is very well intentioned, and who can argue with it? But it's really not practical, and it may not be having the effects that CCO is hoping. The primary function of these sorts of clinics is to ensure that appropriate treatment recommendations for every cancer patient, okay? And for rectal cancer, CCO says you have to have a surgeon, a radiation oncologist, medical oncologist, radiologist, pathologist. Everybody has to be there. It has to be preoperative. Well, really, in our city, the only clinic that serves that purpose is a 1-hour conference at 12:30. And, you know, it's just completely inadequate for preoperative review of every rectal case, rectosigmoid case in the province. And really, so it really demonstrates the problems with, you know, the idea is great, but there are major resource barriers to appropriate review, enough radoncs, medoncs, time barriers, et cetera, et cetera. So through the Quality Initiative in Colorectal Cancer, what we've come up with is a couple of solutions. And the first is an internet-based collaborative cancer clinic. And what we, together with our research team and the support of a number of surgeons at the Juravinski Hospital, using the internet and Mac software, distant learning software, we basically can look at the images on one view while we're chatting with the surgeon. Okay, so here's the referring surgeon, the reviewing surgeon, other physicians as needed, a radiologist, et cetera. And prior to the review, we would ask the surgeon, what do you want to do with your patient? This is a CT scan of a patient with rectal cancer. So do you want to go straight to surgery? Do you want to go straight to radiation, et cetera? And then you would review and focus on these things. The details aren't necessarily that important, but what's fascinating is over about an 18-month period, over the internet, we reviewed 57 cases. And 30 of these 57, or 53%, there was a change in the management plan. So the surgeon said, this is what I want to do. You review it, you have a chat, and 53% of the time there was a change. And 30% of the time was a major change. You know, the patient went straight to surgery or the patient went straight to radiation, in contrast to the pre-review plan, okay? So, you know, that can be a little sobering to think that if I go to a surgeon, the surgeon is advising something, and half the time if they discuss it with colleagues, that plan will change, okay? So that's pretty sobering. The thing is, though, that we also instituted this at our hospital. So the 4 surgeons at the Juravinski Hospital, who primarily treat colorectal cancer, meet every Monday morning, because we said, gee, you know, I wonder if we do this amongst ourselves. And since that time, shortly thereafter, 3 of the surgeons from St. Joe's, so every morning we meet, the 3 surgeons from St. Joe's, the 4 surgeons from the Juravinski, and we present to each other our cases, and we go through the same sort of thing. Okay, what do you want to do, Marco? What do you want to do with this case? Okay, fine, and somebody writes it down. Then we review it. There's a radiologist. And what we found, surprisingly, is that about 40% of the time, we were changing each other's management plans. And what this shows you is 3-month blocks, because we thought, okay, well, look at, you know what, after a first or second 3-month block, we're all going to converge and we're all going to be doing the same thing. But in fact, what we found is that there are certain subtleties, and it's pretty amazing, and medicine doesn't come in a nice little box. And so really, you know, the group coming together is much more important than the single individual just discussing. But the problem is, how do you facilitate that? And I was explaining this to my dad. Nicole knows my dad. So he goes, oh, that's very interesting, Marco. You know, we had a saying in the village, and the saying was, you know, a man and his donkey is smarter than a man alone. So, and I really think that there's some truth to that the group coming together. What's even more fascinating, though, I think, is that it really creates a lot of positive energy and positive feelings and breaks down these barriers. Because I personally think the barrier to quality, optimal quality, often is our own personal issues, our own personal journeys, you know, ego, insecurity, you know, fear, you know, a lot of negative things that don't have to be there. But again, it's difficult to know how to break those down. I have a master's student who just graduated. Mo was on the committee. Thank you very much, Mo. And this wasn't part of her thesis, but she instituted the same thing at Roswell Park, asking the surgeons before their MCC, what do you want to do with this patient? This wasn't just rectal, this was hepatobiliary, et cetera. And she amazingly found the same thing, 36% change. In our internet study with surgeons across the LHIN, in our Juravinski study with surgeons from St. Joe's and Juravinski, and in the Roswell Park study, we're also finding that there's really no patient tumor treatment factor that can predict for post-review change. And again, this suggests to us that every patient really should be discussed. The challenge is how to institute it. So, in summary then, I hope you can sort of see where, you know, my journey has started. I mean, you know, I was in residency. I was exposed to these human rights things. I was exposed to great variability in rectal cancer, and I decided, you know what, this is a really neat area for me to work in, and I think there's a lot of parallels between all of these systems, you know, whether it's education, human rights, or even medicine. And so I decided to focus on medicine and cancer surgery. Ultimately, I think it's about systems, making systemic changes. But when those systemic changes happen, I think we really have to ask, is this to improve quality? And is it equitable? Is it equitable for patients? Is it equitable for staff, nurses, doctors, everybody? And so that's how I've gotten here. Thank you.